Good morning. Well, thanks very much for that introduction. Thanks very much to all of you for coming. I do want to thank, as Sam did, Oasis, and particularly Marilyn Mann and Juliette Simone, who is the Chief Program Officer, for thinking of this opportunity for us to come and speak with you. And we also would like to thank the Missouri History Museum, and particularly Kemi Awoshili, who is a signature special events specialist at the museum. So we're going to talk about an illness that for many years was considered part of the normal aging process. About 40 years ago, the National Institutes of Health established the Alzheimer's Disease Research Program throughout the United States, and Washington University had one of the first 10 Alzheimer's centers. This actually is our 40th year of being an Alzheimer's center. And one of the most important early attributes of the centers is they recognized that Alzheimer's disease is just that, a disease. It is not part of normal aging. Clearly, aging plays a role. The older we get, and I'll show this, the more likely we are to have Alzheimer's, but I know that you are aware of many people in their 80s, 90s, even in their 100s, who are still totally with it and still vibrant and intellectually intact. As a matter of fact, the oldest woman in the world to have a brain autopsy had it at age 115. She was dead, by the way. And there was no sign of Alzheimer's. So it's possible to live long and not have Alzheimer's disease. But I want to begin by indicating again that our Alzheimer's Disease Research Center at Washington University, now 40 years old, is really a remarkable group of research volunteers, clinicians, neuroscientists, and staff, all dedicated to trying to defeat this illness, Alzheimer's disease. We better start with defining terminology. And the first is, what is Alzheimer's? What is dementia? Let's start with dementia. Dementia is an acquired illness that is characterized by memory decline and other memory and thinking abilities, judgment, language. And it's not just a decline that we are irritated about, but it has to be substantial enough that this memory and other memory and thinking decline starts to impede our ability to carry out our usual activities. It affects our daily life. Now, any illness that affects the brain potentially could cause dementia, particularly if it affects the areas of the brain involved in memory and language and judgment. But by far, the most common cause of dementia is Alzheimer's disease. So there are many illnesses that can cause dementia. Here are just a listing of some of them. So not everyone with dementia has Alzheimer's disease, but everyone with Alzheimer's disease will become demented. So we focus on Alzheimer's disease because it is the leading cause of dementia. All these other illnesses can produce dementia, but they're not as frequent as Alzheimer's disease. There is no group of individuals on earth that is protected against developing Alzheimer's disease. So all of us are at some risk if we continue to live long. The number of people worldwide who have Alzheimer's disease is increasing. And certainly in the world, we think that it's going to affect over 150 million people in just 25 years. It's a chronic disease. By that, the onset of the illness until the disease progresses, and I'll demonstrate that in just a moment. It ends always in death. It is uniformly fatal. But this process from onset until the end, until death, takes 7 to 10 years. And remember, people with Alzheimer's disease have dementia, so they lose their ability to carry out their normal activities. And as it progresses, that becomes more and more apparent, which means they have to be cared for. So a chronic disease, and it requires other people to care for the individual who is progressing through the illness. So it's very costly. In the United States in 2022, they thought $360 billion are spent caring for persons with Alzheimer's disease. Alzheimer's disease also is a major killer in the United States. It's listed somewhere as the 5th or 6th leading cause of death. I think it's higher than that. I think it's the 3rd after heart disease, cancer. But often when people with Alzheimer's disease die, they die because they've become unable to swallow, and some fluid, instead of going down into the stomach, gets into the lung, and they develop pneumonia. And then when the person dies, what's written on the death certificate is pneumonia. Of course, the reason they got pneumonia is they had Alzheimer's disease. So it's a major killer. And of all the 10 top killers in the United States, it's the only one for which we have no truly effective therapy. Now, that may be changing, and I hope to tell you about that at the end of this presentation. But you know, the deaths due to heart disease, deaths due to cancers, deaths due to stroke are decreasing, but Alzheimer's disease, until just recently, no effective therapy. So this shows the frequency of developing Alzheimer's disease as a matter of age. So here's the age, and you see right around age 55 or 60, the frequency of Alzheimer's disease increases dramatically. Here in the sort of the grayish is everybody with Alzheimer's disease, so you could say that at age 90, something like 25% of people will have Alzheimer's. But note that in red and in blue are men and women. Men in red, women in blue. Women are at increased risk of developing Alzheimer's. This is what a person with Alzheimer's disease, the brain of a person with Alzheimer's disease looks like. Here is a person who did not have Alzheimer's disease. We're looking at 1/2 of their brain. And here's a person who, let's see, this says healthy brain. The person is dead, so that probably is not a healthy brain. But they didn't have Alzheimer's disease. This person had Alzheimer's disease, and note that the actual brain tissue is shrunken, and the spaces between the tissue are much larger than should be in a normal brain. That's because this is the major problem with Alzheimer's disease. Brain cells die. And when they die, the brain shrinks. And this is what we the first person to have Alzheimer's disease. I'll tell you about her in just a moment. This is a picture of her brain under the microscope showing signs of brain cell death, something called the plaques and the tangles. This is more modern stage. This is all microscopic, but we see these plaques, and then the brain cells have aggregates of a material that should not be there, meaning the brain cell is dying. So this person, I'm sorry the photograph is so small, but it was taken when she was age 51. In 1901, she was admitted to an insane asylum in Frankfurt, Germany. And the admitting physician at the insane asylum was a man named Alwas Alzheimer. And he got the story from this woman's husband. Her dementia began about 4 years earlier at age 47 and progressed. And remember, Alzheimer's dementia affects her ability to carry out daily activities. So over time, she was less and less able to do what she was accustomed to doing: cooking, shopping, doing the laundry, and gradually the husband had to take over. And as that happened, it brought him into contact with other women, and she developed a really terrible fit of jealousy whenever he would talk to another woman. And this was terrible because he couldn't go to the market and shop and talk to shop lady without this woman flying into a fit of jealous rage. It was particularly problematic in the apartment building where they lived, because for some reason this woman had the idea that a neighbor lady was having an affair with her husband. She would keep everyone up at night screaming insults and terrible things, and eventually it just was too much. So he brought her to the insane asylum where Alwas Alzheimer examined her. And then when she died, what Alzheimer did was use new techniques to find these indicators of brain cell death. He reported this case in 1906 to a group of psychiatrists in Germany, and no one thought much of this until we finally, 100 years later, recognized the significance of this discovery. This is not aging, this is a disease, and these are the markers of the disease. In 2006, I was flattered. I was invited to go to the very same place of that conference where Alzheimer presented his first case, and I was asked to give a lecture about this. And after the lecture, I met a German neurologist who had researched all of the history of this first case, and he told me something about this woman's husband, the husband who admitted her to the insane asylum. Of course, when she died, he was a widower. They had children, so eventually he remarried, and of course he remarried that neighbor lady. All right, risks for Alzheimer's disease. Number one, getting older. That's the number one risk factor. You saw right at age 55 or 60, it just increases in frequency. The older we get, more people are living longer, more people are getting Alzheimer's disease. Second, genetics. And this is complicated. There are a few genetic disorders that if one has it, you will get Alzheimer's disease. The first is Down syndrome. I don't know if you're aware that every person with Down syndrome, if they live to age 40 or beyond, will have Alzheimer's disease. There are families in which a certain gene, a normal gene, is mutated. It becomes abnormal. There are 3 such genes. These are the designations for that. And an affected person with one of these gene mutations will absolutely get Alzheimer's disease, and usually at a young age, again, around 45. That person, if they have children in their 20s and 30s, they could pass that gene on to their offspring. Each offspring would have a 50-50 chance of inheriting that gene. If they inherit the gene, they're going to get Alzheimer's disease, usually around age 45. If they don't inherit the gene, they're at no more risk than anyone else. This is a very rare cause of Alzheimer's, less than 1% of everyone with Alzheimer's. Most people with Alzheimer's do have some genetic risk, but the important issue here is risk, not cause. So lots of people say, well, my mother developed Alzheimer's, I'm doomed to develop Alzheimer's disease myself. Well, you can inherit a genetic profile. It won't cause the disease, but it puts you at greater risk. Let me try to illustrate it this way. I don't know if you can tell, a long time ago, I used to have red hair. And my parents also were of Northern European heritage and sort of very pale skin like me. And I remember as a boy when I would go to the swimming pool or go out to play, always at risk of being sunburned. So my genetic risk from my parents gave me lack of pigmentation, which puts me at risk of getting sunburn. But I wouldn't get sunburn unless I went out into the sun, right? It doesn't cause me to get sunburned, it puts me at increased risk. So we can inherit genes that won't cause the disease, but put us at increased risk. Can we protect against Alzheimer's disease? Well, this is controversial. There are some genes that may confer some protection against Alzheimer's disease. How many have heard of the Mediterranean diet? So lots of interest in eating healthy, which, mostly means eating things that don't taste so good. No. No, eating healthy, I think, is an important aspect of it. And our physicians here and I advise our patients to eat a heart-healthy diet, Mediterranean or otherwise. Some people think that drinking red wine might be protective. I've always been a little dubious about this because that first report that red wine might be protective came from a group of scientists at the University of Bordeaux in France. But I think here the bottom one is most important. Stay active, engaged lifestyle. Stay physically involved, cognitively intact, and socially active. I don't know that it will prevent Alzheimer's. It will not hurt, and it may help. So we all recommend it. I'm going to skip this slide and talk about this. One aspect of research is that we depend upon people to volunteer, to come in and be participants in our studies. We can evaluate them and test their memory and thinking. We can do images of the brain. We can examine the blood and try to understand the disease. We're very, very thankful to our research volunteers. However, our research volunteers, by and large, are not really representative of the general population. For example, in our Alzheimer's Research Center, the number of years of education on average for our volunteers is over 16 college graduates. So we always have to realize that what we learn in our research participants, we have to also take out into the real world, to the general community, and evaluate whether it is as we found in our group of volunteers, or whether it is changed in the real world. The real world, people are probably less educated, less affluent, probably have more chronic diseases, and the disease may manifest differently, and response to therapy may manifest differently. So we're always interested in translating our research findings to the general population. All right, so I've talked about Alzheimer's disease. It's a brain disorder, nerve cells die, and it ends up causing the loss of brain cells. But the process begins probably in midlife, maybe as early as age 45 to some people, or 50, and it takes 2 decades or longer before that process of brain cell death builds up to cause the dementia, the loss of memory and thinking. Then, and I'll illustrate in the next slide, we all recognize Alzheimer's disease when people have dementia. At our Alzheimer's Disease Research Center, we're very interested in this asymptomatic, this preclinical stage when people are cognitively normal, but the brain process has begun, because our idea is ultimately we're going to defeat Alzheimer's disease when we can intervene there before the dementia and try to delay or even prevent the dementia onset. This is nothing unique to Alzheimer's disease. That's what we do with heart disease, right? People don't wait till they have a heart attack to try to control their blood pressure or their cholesterol. They take medications to prevent the heart attack, and that's what we want to do with Alzheimer's. I'm going to skip this slide and just go through this here. So the disease begins very, very gradually. It's hard, difficult, maybe impossible to pinpoint just when it begins, because the early symptoms are so mild, it's hard to know what's going on. But as it progresses, people become forgetful. They tend to repeat themselves. They'll ask the same question that's already been answered or tell the same story. And their judgment begins to become problematic as well. Often this shows up in complex activities such as driving an automobile. But by and large, they look and act normal, and they still may be involved in things such as driving. Certainly they go and vote, they may continue to try to manage their finances. They're not doing it as well as they once did, but they're still doing it. As the disease progresses, then pretty much only things they've learned from long ago do they remember, and they have really no real ability now to leave the home unless they're accompanied by a family member or other caregiver. And in this stage, the middle stage, they can start getting some of the behaviors that people are concerned about, irritation. They can become difficult to handle, and it's at this stage that most families are looking to try to consider whether they need to be in a memory care facility. The end stage is terrible. They don't recognize anybody. They often lose the ability, I mentioned earlier, to swallow properly. They can't walk. They lose control of bladder and bowel. And eventually, of course, they die. Over 7 to 10 years period is this entire course. I've already mentioned that I think now the field has come to recognize that truly healthy aging is possible. It may take longer to do things, but people who are free of Alzheimer's disease will still make accurate judgments and correct decisions. And if they're not doing that, that's not because of age, that's because they have a disease such as Alzheimer's that is associated with aging. So cognitive decline, memory and thinking decline, is not an indication of age, it's an indication of disease. So this is the therapies for Alzheimer's disease. The first therapy that was approved by the Food and Drug Administration in 1993 was a drug no one knows because it was very difficult to use, called Tacrin. 1996 came a drug called donepezil. The trade name for that is Aricept. And then some other drugs came along up until 2003, the last one being memantine. All of those drugs help the symptoms of Alzheimer's dementia. They don't really get at the disease process that causes the brain cell death. So they help symptoms minimally, but they don't get at the disease. Just in 2003 and again in 2023 and 2024, we have two new drugs, lecanemab and donanemab, that get at the process that causes the brain cell death. So we're in a new era now, not just treating symptoms of Alzheimer's, but trying to treat the disease itself. Lecanemab is an anti-amyloid drug. Amyloid is one of the proteins that gets misfolded in Alzheimer's disease and causes nerve cells to die. And now it is being used in academic medical centers and in some private medical centers. And it does seem to benefit people with Alzheimer's dementia. Two issues. It does not stop the progress of Alzheimer's dementia. It does not stop it, but it slows the rate at which it occurs. So people don't deteriorate as rapidly as they would if they weren't on the drug. Number two, the earlier the drug is administered in the disease process, the better the result. If we wait till people are in the more moderate stage or even the late mild stage of the disease, they're not going to get the same benefit. So early detection is important. And now we have a way to do that as well. So we have disease-modifying drugs now in the past 2 years, and now we have a blood test that can cause detect Alzheimer's pathology. A whole list here. I'm not going to go through all these, obviously, but we have them, and now they're, at least one of these is approved by the Food and Drug Administration, and hopefully will soon be, if not now, soon will be reimbursed by insurance carriers. So we can now detect Alzheimer's disease by a blood test. And we need to do that, again, because we want to get individuals, identify individuals as early in the disease process as we can, because that's when the initiation of therapy is most effective. And I'm going to skip through all this, and we'll talk about that during the question and answer. So I am very appreciative that three of our leading faculty members in the Alzheimer's Disease Research Center have come here to answer questions about Alzheimer's disease and also correct any mistakes or misinformation that I've provided you. So may I call our panelists up? We can lift the screen. Andre Denny is a lawyer and a social worker and is a leader of our outreach, recruitment, and engagement corps, but has a wealth of experience in dealing with Alzheimer's disease and its effects on families. Jonathan Williams is an assistant professor of neurology at the School of Medicine and joined the Alzheimer's Disease Research Center about 1.5 years ago because he's very interested in the brain function and how it affects memory and thinking. And Suzanne Schindler is a neurologist, and she is a leader of our fluid biomarker corps, and a world expert in some of these blood tests for Alzheimer's disease. So will you please join me in inviting Andre, Jonathan, and Suzanne to the chairs. Now, we want to make this open for your questions. So Jennifer Phillips is here, I think, and has distributed index cards to people. And if you want to write your question down, you can bring it to me, then we'll try to ask our panelists about this as well. So I have a few questions here, and I'm going to ask Suzanne Schindler to begin to talk about the availability of a blood test. Can the audience members here, Dr. Schindler, just go to their primary care physician and get a blood test for Alzheimer's disease?
So it's a little bit more complicated than that, as you might expect. So there are a number of blood tests that are now available, and they can be ordered from major laboratories like Quest Diagnostics and LabCorp. However, appropriate use recommendations say these should only be ordered for patients who have cognitive impairment as part of a clinical evaluation. So these are not tests to be done just to check. They're meant to be used when someone has cognitive impairment, and the question is, whether their cognitive impairment may be due to this Alzheimer's disease brain pathology or not. I would note, though, that these tests can be ordered not just by neurologists, but also by primary care providers. And we are seeing an increasing number of patients come to our memory clinics who already have these test results because they were ordered by primary care physicians. So in some ways, yes, your doctor can order this if they're concerned and they're doing a workup, but it's not just in everyone.
Do they cost money?
Everything costs money. So these tests do cost money. Some of them are $200. Some of them are $1,500. We're finding that insurance is increasingly paying for these. So your insurance may pay for it, or your insurance may not pay for it. So there's some variability right now in terms of whether there's insurance coverage or not. The expectation is that over time that insurance will cover this most of the time.
Okay, thank you, Dr. Schindler. Dr. Williams, I spoke a lot about Alzheimer's disease as a leading cause of dementia. Is it common for Alzheimer's disease to be the only brain problem when people examine the brain tissue after death, or can other illnesses exacerbate Alzheimer's disease?
That's a great question. Hey, everybody. Thank you for having me here. What I'd say is that it's not uncommon for dementias to be mixed. And by that, you can have more than one thing going on. Just like humans, diseases can be complicated. And how we live, the things that affect us during our life affect our brain and our brain health. And so you think about things like, hypertension, diabetes, obstructive sleep apnea. Those things can have an effect on our overall health. They have an effect on how our brain develops. And then when we're through using our brain, as others would say, you can see evidence of that, and that can affect the severity of disease. As a practical matter, it can make it really hard to figure out what's going on and what explains what in real life when you've got multiple things going on. And so that's really one of the best ways that we're able to differentiate one type of dementia or one thing from another, really looking at what's going on in the brain after death.
So I 100% concur with Dr. Williams about this. One of the issues, we touched upon this when we talked about the Mediterranean diet, but it turns out that what's bad for the heart in middle life, so hypertension, cholesterol, diabetes, smoking, is bad for the brain in late life. And it's not uncommon, if we were to do an autopsy study of someone with Alzheimer's, to find signs of vascular disease in the brain. So it's very important that we understand Alzheimer's disease, but it often, just as Dr. Williams said, does not occur in isolation by itself. Okay, Andre Denny, this is an easy question for you. Will Kennedy slow down research? Or maybe, what can we do to ensure research funding remains a priority?
Well, we all have a voice, and of course we should always talk to our elected officials to be sure that they know if you think it's important, I think it's important. We're so close with some of these things, like these newer treatments and the blood tests, it would be a terrible time to lose progress. So I would say to advocate. The Greater Missouri chapter of the Alzheimer's Association goes to Jeff City and sometimes goes to DC, and there's ways, if you wanted to get involved and advocate, to find organizations that will help you lift your voice.
Very well put, thank you. All right, Dr. Schindler, what about brain supplements? Will that help with memory? What about Prevagen?
So I do think, as you talked about, there's an important role for diet, and we want a heart-healthy diet. But a lot of these supplements are way past that, and you're actually taking a lot of things that you already get in your diet that you don't really need. And so basically, you just excrete them. So they really, many of them don't help you in any way. Prevagen is a product that has great marketing and almost no science supporting its use. Unfortunately, because it's considered a health food, they don't actually have to have any science supporting it. And so they make all these claims. I think the way that I would describe it is a scam. So I would caution you on some of these things. They do have this kind of veneer of legitimacy, the way that they're marketed. You see them on TV, but they are not FDA approved. They do not have strong science supporting that they actually do anything. They're completely different than the treatments that Dr. Morris was describing, who have been through a very extensive scientific vetting process.
There is one biologic effect that these supplements do have, and that is they will make your urine more expensive. So, Dr. Williams, a question again about the risk factors for Alzheimer's. I talked about Down syndrome and why children with Down syndrome or adults with Down syndrome are more likely. What do you understand why Down syndrome people are at greater risk for Alzheimer's?
Well, yeah, sure. And so, start by saying just the genetic underpinning. Well, just aside from the jargon, the genetics of it. What are your risk factors? And so, with all Down syndrome specifically, the problem is with the chromosome, specifically 21. Sorry. And so because of the other things going on, again, that increases. Nothing happens in isolation. That increases the risk for the buildup of things that hurt the brain, and that leads to the development of dementia. And in other ways, thinking beyond just Down syndrome, I'm a neurologist, and my specialty is epilepsy. And so what I've seen, or when I got interested in this disease, just for those who don't know, epilepsy is a study of seizures and seizure disorder, is that people who have epilepsy have a higher risk for dementia. And so that's really, the awareness of that, awareness of how these things play into each other, and the overlap of symptoms. And so with seizures, you can have a lot of the same types of things: memory problems, thinking problems, gaps, and loss of time that can, in other populations, that maybe represent dementia symptoms. And so, again, I heard somebody in this direction when the first key speaker was going on saying, "This is so depressing." And I think that's right. But the silver lining is, as we gain an understanding of these different things and how they're connected and how they work together, then that's part of the answer to making them better. And so we live in a time now where there are more screening tools and also more treatments that are being developed. And so it's important to understand what's going on, find the right problem, and find the right solution for that problem.
That's a great response, and it really leads into these a couple of questions about, I'm getting older, I'm generally healthy, but I'm worried about my memory. Should I get tested, and if so, how? Andre Denny, how can people get tested, and should they get tested?
Well, I think anytime you have a concern about anything, and now that you've heard from Dr. Morris and others that this is not normal aging. If you're aging, this is, something to consider. You would probably start with your primary care doctor or your clinic that you go to or whatever and say, look, I'm starting to have these concerns. Could you do some kind of screening or help me? And usually the primary is the first place you go to get a basic screening. And if they note that something is wrong, they will usually refer you to a specialty practice like a neurologist or sometimes a geriatrician or someone that really has a specialty, especially now as the science is changing and it's more cutting edge. I think it's really important to get to a specialist.
So, Ms. Denny is a very kind and considerate person. And she said, usually your primary care physician will make the diagnosis and make a referral. I'm much older and meaner. And I'm going to say that most primary care physicians simply don't have the time to sit and understand what's going on. And if they diagnose Alzheimer's disease, this is the mean part, and I don't in any way fault the primary care physicians, but to care for an Alzheimer patient takes tremendous time and resources, and they don't simply have it. So 50% of people in the United States that have Alzheimer's dementia are undiagnosed. They don't have a diagnosis. Ms. Denny said, what you really want to do is get to a specialty clinic. I agree with that, but there are so few specialists, and the wait is so long for many of them. To see Dr. Schindler, you might have to wait a year. So this is a problem of access, and it's just terrible. Now, what Mrs. Denny said, again, I don't mean to call her out. She said that as the treatments become available, as the blood tests become available, become accepted, maybe things will change. People will see value in making an early diagnosis and getting the proper therapy. But right now, it's hard to get a diagnosis unless you see a specialist, and it's hard to see a specialist. So someone asked, why is age such a risk factor for Alzheimer's disease? So we didn't spend a lot of time on the proteins in the brain that we think are at the crux of the Alzheimer process. One of the protein is a normal protein. So we all have it, circulates in the brain, it's in solution. It's called amyloid beta. We don't really know what that protein does in the brain, but it's there. But if for some reason too much of that amyloid beta gets produced by the brain, or the mechanism to sort of clear it out of the brain becomes compromised, the concentration of this amyloid beta builds up, and it turns out to be a very sticky protein. It will clump together. When it comes together, it no longer is in solution. It becomes a solid mass, and it gets deposited in the brain tissue. It's called the amyloid plaque. The mechanisms of the brain say that amyloid plaque shouldn't be there. That's not normal. Amyloid beta should be in solution. So it attacks the amyloid plaque, tries to get rid of it. Inflammation, all kinds of stressors to get rid of it. The problem is the attack mechanisms don't differentiate between the abnormal plaque and the normal brain tissue surrounding the plaque. They kill everything there. So the cause, we think, a major cause, perhaps the major cause of Alzheimer's, is too much production of amyloid beta or abnormal slowed clearance of amyloid beta, causing a plaque to form which sets off the reaction that kills the brain tissue around it. We mentioned Down syndrome. Well, I also talked about some genes that if you inherit it, you're going to get Alzheimer's disease. Down syndrome individuals have an extra copy of the gene that produces amyloid beta. You know, of course you remember your genetics, and you know exactly that you get one chromosome from your mother, one from your father. You have pairs of chromosomes. In Down syndrome, one parent, usually the mother, gives two chromosomes, and the father gives one. So now the Down syndrome individual has three chromosomes. It's a particular chromosome that encodes, that causes amyloid beta. So they're overproducing amyloid beta by 50%, Down syndrome individuals, from the time of conception. They build up amyloid in the brain. That's why they all develop Alzheimer's dementia. Those gene mutations I said that are so rare, but if you inherit it, you're going to get it. They cause too much production of amyloid, just like the Down syndrome people. The question was about age, and one theory, it's not yet fully proven, but it could be as we get older, our ability to clear amyloid beta from the brain is compromised, so it increases the concentration, causes it to clump and form the plaque. Couple of questions for Dr. Schindler. The same question. How long to wait to get treatment? When should people go get diagnosed so they can get treatment? Is it that mild cognitive impairment? Dr. Schindler is the world expert on mild cognitive impairment. Should I wait a little while? And if so, if I wait, is it too late?
So really the answer is it's best to come in as early as you can, because that's when we think these treatments are most effective. But it's difficult, right, to know when that starts, because I don't know about you guys, but we all have some cognitive impairment from time to time. We have some lapses here and there. And so it can become a little difficult to know when things have changed. However, when we talk to our patients, we do hear, that things have changed. So for the last 6 months or the last year, people are repeating questions, they're missing appointments, they're misplacing items more often than in the past. So those are the sorts of early symptoms that we typically hear about, and we hear that, over the last 6 months to a year, that these symptoms have progressively worsened. They're not going away. They're becoming more consistent. That's really the kind of scenario where this is exactly when we want people to come in and see us. Unfortunately, sometimes people wait. They wait till things get worse, until it is impairing their function and activities of daily living. And we can still treat people for a little while until they really develop more impairment in their activities of daily living. But the longer we wait, the less effective these treatments are. So we do want people to come in earlier. And so if people are experiencing a change from the past for them, then it's a good idea to get checked out. And keep in mind that if you try to get an appointment to see a memory specialist, that it typically does take 6 months to a year. So if you're seeing these concerns, don't wait, because it may be a while till you can get in to see somebody, unfortunately.
So Dr. Schindler, I told our audience here that what we really want to do is not wait to even the earliest symptoms of Alzheimer's disease, but try to intervene before there are any symptoms of Alzheimer's. Prevention. Why can't I get a blood test now and get the drugs right now, even though I don't have memory problem?
So that's where the field is going. Unfortunately, we do not. So there are trials underway that are looking to see whether these treatments prevent the onset of symptoms, but the trials have not read out yet. And unfortunately, in the Alzheimer's disease space, we've had quite a few negative trials. So things that we thought might work didn't end up working. So it is important to wait to find out what the results of these trials are, to make sure that these drugs actually do slow or prevent onset of symptoms. It is quite possible that, say, 3 years from now, these trials would have read out as positive and shown that these treatments actually do slow down or stop the onset of symptoms related to this Alzheimer's disease brain pathology. If and when that happens, we will all be thrilled. And that's a point where we could start talking about screening people who are asymptomatic with blood tests. There's still going to be a lot that goes into this because it turns out that a lot of people who are older than age 65, 70 actually have some amyloid in their brain, and many of them will not develop symptoms from it. So we have to figure out who should we treat and when should we treat. There's a lot of questions outstanding. But for right now, we do not recommend testing individuals who are symptomatic. We don't have treatments that can be given to people who are asymptomatic, but hopefully it's coming.
Thank you. Dr. Williams, what is lamotrigine used for, and does it have a role in Alzheimer's disease?
It's a great question. So lamotrigine.
Usually when we tell you, that's a great question, we don't know the answer, we're just but go ahead.
So lamotrigine is actually a seizure medicine, anti-seizure medicine. I'm very familiar with that specific one. Actually, I believe was developed initially as a headache medicine and approved in around 99 or so, maybe a little after that. One way it can be interesting, especially with people who have cognitive complaints, is that for a long time we thought that maybe it doesn't. These medicines for seizure, a common complaint is that they affect your cognition. They can slow your thinking, slow your processing, cause all sorts of other side effects. We give them because we expect them to help with the underlying problem. In my field, it's seizure. But when somebody's taking something that affects their cognition, that can cause other issues, right? If you can't think as well, if you can't think as fast, then that's his own issue. In people who have dementia and have seizures, oftentimes lamotrigine was thought of to be a medicine that might not have as many of the cognitive effects, and so we liked it. I also thought of it as being a little bit more energizing instead of making it sleepy. And so some recent evidence that maybe that's not as clear-cut as we thought, and as Dr. Morris here might have mentioned that one, because we actually did some work on that area to look at these different medicines and see the effect on cognition. And so for that one, there was mixed evidence whether it was as safe as we thought, and it had mixed results in some of the people taking it. So I think it just underscores the point of things are complicated, and you want to understand the effect that each different variable is having on somebody, and that way you can help really interpret what's really going on.
I want to bring up a complaint that people sometimes have as they get older. Matter of fact, a lot of us may have as we get older, and that is, I have difficulty coming up with names of things or names of people. And it's so frustrating to me. I know what I'm talking about, I just can't come up with that name. Is that a sign of Alzheimer's? I think the vast majority of the time, no, if later that name comes to you. Because then it's not a memory problem, right? The name is there. It's a retrieval problem, getting it out when we need it. And that is something that, unfortunately, we experience as we get older, the delay, the retrieval, slowing of the processing, okay? It will still come, and if it comes, it is not a sign of Alzheimer's disease. Last question, and it's a tough one, and I'm going to have Ms. Denny talk about it. How do you bring up the possibility of Alzheimer's disease when you suspect it in a loved one, particularly in the early stage, and is that going to cause angst and depression, and how do you do it?
I'm so glad someone asked that, because I actually wanted to circle back and say one thing that hasn't come up is that a lot of times, sometimes the person that's having the memory and thinking changes doesn't have what I think they would call insight. So they don't even know. Sometimes people are like, oh, they're so denial. Sometimes it's not denial. They literally don't know the changes. And in our research and also in our specialty practice, everyone that comes in has to come in with someone that knows them well, because that really fills out the picture. I like to use the example of my aunt, who unfortunately died of Alzheimer's. If you asked her how her memory was, she would say, oh, honey, it's fine. And someone needs to be there to be like, well, she did miss her last 5 appointments, or she asked the same questions and things like that. So sometimes, though, you start seeing it in someone you love and care about, and it's a hard topic to bring up. I think it will get easier and easier as we know the earlier you do something about it, the more that can be done. And there are sometimes things that mimic some of these memory changes that might be treatable and dealt with, not often, but you know, a metabolic panel and checking. Look, I'm not a doctor or nurse, so I don't know why I'm the one talking about this, but try to convince them, let's go see if something's going on. I'm noticing just a couple of things, and sometimes if someone is really resistant, now you can call a doctor's office. They can't give you information about someone, but you can call the primary ahead of time and just flag some concerns so that hopefully when they go in and see their doctor or their person, that'll be checked. And look, there is like the Alzheimer's Association has a helpline, 1-800-272-3900. I used to be a volunteer on that helpline, and sometimes people will call and say, I can't get my mom to go to the doctor. And sometimes there's a person that can kind of talk to you about your individual situation and give you some tips and ideas of how you might finagle that person to convince them. Sometimes, depending on your relationship, it's just a really loving conversation, and sometimes it's if they won't do it for themselves, it's like, would you do this for me? Sometimes people will do a lot of things for you that they won't do for themselves.
So we have to wrap up. Outside, I think, are some tables with information from Memory Care Home Solution, Oasis, and the Knight Alzheimer's Disease Research Center, so feel free to avail yourself of that information. Great questions from you. Thank you very much. And terrific panel. Let's thank Dr. Williams, Dr. Schindler, and Ms. Denny, and thank all of you, and take care.